Today we welcome Professor Gary Koch, who is Director of the Biometrics Consulting Laboratory and Professor of Biostatistics at the University of North Carolina at Chapel Hill, where he has served on the faculty since 1968. He received a bachelor's degree in mathematics and a master's degree in industrial engineering from Ohio State University and a doctorate in statistics from the University of North Carolina. He also holds an honorary doctorate from De Montfort University in Leicester, UK. Dr. Koch has had a prominent role in the field of categorical data analysis and applications to a wide range of settings in the health sciences. He teaches classes and seminars in categorical data analysis, consults in areas of statistical practice, conducts research, and trains many biostatistics students. He currently serves on the editorial boards for Statistics in Medicine and the Journal of Biopharmaceutical Statistics. He's published extensively on methodology related to crossover studies, multi-center studies, longitudinal studies, rank methods for ordered outcomes, covariance analysis, adverse experience data analysis, and multiple comparisons. And today, Dr. Koch will speak to us about statistical methods to address multiplicity. Thank you, Gary, for joining us today. Really appreciate it.
Thank you. It's good to be here and to discuss a topic that arises in many confirmatory clinical trials. I'll try to access the slides now. So hopefully the first slide has appeared. Do you see that, Beth?
I can see it. Can those in the room see the slide, Charles? Okay, yep, it's okay.
So the title is Statistical Methods to Address Multiplicity, and the scope includes methods for multiple endpoints, comparisons among multiple treatment groups, and comparisons that include pre-specified subgroups in addition to all randomized patients in a clinical trial. Statistical methodology strengthens robustness of study findings to sources of bias. This is achieved by randomization and masking of the assigned treatments. Variability, this is addressed through sufficient sample size and to some extent by adjustment for prognostic baseline covariates and offsetting spurious outcomes. This can be addressed also by covariance adjustment, but the main concern for avoiding spurious outcomes is the management of multiple comparisons. Multiple assessments lead to multiple opportunities for findings to be due to chance and so need control. Multiple assessments arise for a confirmatory clinical trial through the assessment of multiple endpoints, which can include more than one primary endpoint, as well as one or more secondary endpoints in addition to a primary endpoint. Comparisons among multiple treatment groups, as might occur in studies that address two or more doses of an intervention in addition to a control treatment. Multiple inferences for subgroups, where a study may specify not only all randomized patients as a primary population, but also patients with a particular combination of baseline characteristics where the effect size might be believed to be bigger than what it could be in other subgroups. And then there's also multiple interim analyses where the data will be looked at one or more times prior to study completion. There is also a notion of multiplicity when multiple types of analyses are required, particularly those to address missing data, but there the issue of multiplicity affects the type 2 error or power rather than the type 1 error that is associated with the other areas. The issues for multiple assessments are initially avoidance of inflation of type 1 error from insufficient control, but importantly, avoidance of unsatisfactory loss of power, that is excessive type 2 error, to detect real treatment differences from overly burdensome control. Many clinical trials to compare 2 or more treatments have multiple endpoints. This can occur when there is a single criterion that has assessment at several visits during a clinical trial. For example, patient global ratings of symptom control for a respiratory disorder at 4 visits during the treatment period, or 4 different dichotomous criteria for outcomes of treatment of stroke, 3 time to event criteria for chronic obstructive pulmonary disease for patients followed over time, 7 measures of severity of rheumatoid arthritis that include swollen joints, tender joints, global assessments, and other criteria, as will be noted later, 3 measures of severity of benign prostatic hyperplasia. Strategies for managing multiple endpoints need to have strong control of type 1 error, and often these criteria are specified with one-sided alpha, mainly because with these criteria, the assessments need to be in the predicted direction in order for the methods that provide strong control to work appropriately. And virtually all of these methods belong to what is sometimes called a closed testing procedure. And we will describe some closed testing procedures subsequently. A very standard method of managing type 1 error is hierarchical or sequential assessments. These require p less than alpha at each step of a successive step in a hierarchy to continue. Formal testing stops at the first step with p greater than alpha. For example, the hypotheses could be H sub 0(1), H sub 0(2), and H 0(3) as shown here. However, if H 0(1) is tested first and significance is required for it before proceeding to H 0(2), the real second hypothesis is H 0(1) union H 0(2). And that's because to reject H 0(2), both H 0(1) and H 0(2) must be rejected. And similarly, the real hypothesis for H 0(3) is its union with H 0(1) and H union 0(2), again, because to contradict H 0(3), there must be contradiction of both H 0(1) and H 0(2), in addition to contradiction of H 0(3). A closed testing procedure requires the rejection of a given hypothesis and its intersection with all other hypotheses by methods that control type 1 error in order to contradict the given hypothesis. But the intersection of H 0(1) with the union of H 0(1) and H 0(2), as well as with the union of H 0(1), H 0(2), and H 0(3), is actually H 0(1). And that's why the contradiction of H 0(1) is sufficient for this procedure in its own right. And the intersection of H 0(1) union with H 0(2) with the 3-way intersection is the 2-way union. And so again, once that union has been rejected, it is possible to reject both H 0(1) and H 0(2). Another type of closed testing procedure is based on multi-way averages, and we will describe that method in the next slide. Another type of method is an alpha propagation method, and a well-known method of this type is called the Bonferroni-Holm method. With 3 hypotheses like H 0(1), H 0(2), and H 0(3), it is possible to contradict the hypothesis with the smallest p-value if p is less than alpha over 3. And if p is less than alpha over 3 for that hypothesis, it is also going to contradict the intersection with the other two hypotheses and the three-way hypothesis. And if that hypothesis is contradicted, then one can proceed to the hypothesis with the second smallest p-value by assessing whether it is smaller than alpha over 2. And if it's less than alpha over 2, one proceeds to the third hypothesis. And if it has a p-value less than alpha, that also contradicts that hypothesis. And this method, again, is a closed testing procedure. Another approach to multiplicity is through composite endpoints, where the multiple endpoints are combined together, and one assesses the composite endpoint as an overall way of addressing all of the endpoints. And some studies will involve combinations of these types of procedures. So one of the methods that is a closed testing procedure that is potentially available is due to Lehmacher. And it involves a comparison between groups for the separate endpoints that are of interest and the use of methods that encompass all of the methods. Separate tests for each endpoint at level alpha can be supportive, but does not control the experiment-wise error rate at alpha in the strong sense, except when the number of endpoints is equal to 2, and the overall test also contradicts the overall assessment. A closed method, which is applicable to the separate endpoints and does control the experiment-wise error rate at alpha in the strong sense, requires p less than alpha for that endpoint and for comparable tests for all possible subsets of endpoints which contain that endpoint, including the test for all endpoints. And the Bonferroni-Holm method will also do this as described previously. But when the multiple endpoints are correlated with one another, the use of the concept of a multi-way average can be somewhat more powerful. So in this example, the multiple endpoints correspond to patient global ratings as excellent, good, fair, poor, or terrible at 4 visits to address symptom relief during a treatment period for a respiratory disorder. Visits 2 and 3 are primary, and visits 1 and 4 are secondary, because discontinuation of concomitant medicines was invoked after visit 1 and applied to visits 2 and 3. Comparisons between true treatments for 111 patients through a GEE, that's generalized estimating equations, repeated measures, proportional odds model, is invoked for these ordered categorical outcomes. And the model included treatments, centers, visits, and treatments by visits. The multiplicity is managed with the following successive steps, which combine the closed testing method of Lehmacher with a hierarchical or sequential closed testing method. So the first step was to test the average of the odds ratios for visits 2 and 3. And if one-sided p is less than 0.25, then the testing proceeds to step 2, because the null hypothesis would have been contradicted for visits 2 and 3 averaged together, with that being a useful assessment in its own right, as well as a method to control multiplicity for the separate assessments of visit 2 and 3 at the second step. Because if you contradict the average of the odds ratios at visits 2 and 3, at most one of them can be null. So that means that the separate testing at visits 2 and 3 can proceed at the full 0.025 level. And if one-sided p is less than 0.25 for both visits 2 and 3, there is still alpha left to spend, so the testing can then proceed to step 3, where the average odds ratio is tested for the visits 1 and 4. And if one-sided p is less for that, then one can then proceed to the last step and test visits 1 and 4 separately at the full one-sided 0.25 level. For this particular example, the respective p-values were less than 0.001 for the visit 2 and 3 average of odds ratios, less than 0.001 for visit 2 and 0.001 for visit 3, So the null hypothesis of no treatment difference is contradicted for both visits 2 and 3. So the testing then proceeds to visits 1 and 4, for which the average has a p-value of 0.27, and it's 0.27 for visit 1 and 0.11 for visit 4. And then with covariant adjustment for age, baseline, and gender, all one-sided p-values were less than 0.006. It is also possible to do a non-parametric based rank analysis using stratified counterparts of the Wilcoxon rank sum test. So in that case, differences of mean ranks at visits 2 and 3 are averaged together and tested first. And if that has a p-value under 0.25, then visits 2 and 3 are then tested separately with that stratified counterpart of the Wilcoxon rank sum test, which is often called the Van Elderen test. This next example involves multiple endpoints corresponding to 4 dichotomous outcomes for assessment of TPA for stroke. And the 4 outcomes were the Barthel Index, the Modified Rankin Index, the Glasgow Outcome Scale, and the National Institute of Health Stroke Scale. These 4 outcomes were considered together because in previous studies that addressed stroke, where one of them was specified as primary, the study failed because the specified primary failed, but one of the others actually had a p-value below the specified alpha. But then in other studies where that one may have been specified as primary, it also failed, but then one of the others also had p less than alpha as a secondary. And so to address this particular concern, it was agreed that the primary anethos would actually consider all 4 of these outcomes jointly through a generalized estimating equations logistic regression model. And this was one of the first applications of generalized estimating equations with logistic regression in the early 1990s to a major clinical trial. In this clinical trial, the separate dichotomous endpoints had a secondary role and did not actually have a pre-specified multiplicity method. But the previously multi-way average method with closed testing, as described in the paper by Lehmacher, would have been applicable because one could have tested the pairwise averages of odds ratios and the 3-way averages of odds ratios, in addition to the primary 4-way average of the odds ratio in the generalized estimating equation method. And that would have then produced a bridge to each of the separate endpoints. But the primary criterion, which involved averaging the 4 odds ratios across the 4 endpoints for Barthel, Modified Rankin, Glasgow, and National Institute of Health, had a p-value of 0.008 with the odds ratio of 1.7 and a confidence interval from 1.2 to 2.6. And as such, it represented a composite endpoint that demonstrated the efficacy of the TPA stroke medicine that was applied in this trial. But intriguingly, all of the separate dichotomous endpoints had 2-sided p between 0.019 and 0.033. And so the method of Lehmacher would have indicated statistical significance for each of them by also indicating statistical significance for the 2-way averages of odds ratios and the 3-way averages. There are linear counterparts of these methods that would work similarly with risk differences. Those were not identified in this study, but they would be applicable with generalized estimating equation methods. Now, in this particular example, it's a clinical trial for patients with chronic obstructive pulmonary disease with 3 time to event endpoints. The multiple endpoints correspond to time to severe status for lung function or death, time to very severe status for lung function or death, or time to death, where lung function was measured by forced expiratory volume. Comparisons between the test and the control treatments for an illustrative example of 2,000 patients are based on the Wei-Lin-Weisfeld method for parallel proportional hazards models for the 3 times to event, with these including baseline lung function, current smoking status, age categories, gender, body mass index categories, race, and geographical region. The separate results for the 3 times to event have hazard ratios and confidence intervals shown here. For severe outcome or death, the hazard ratio was 0.806 with a p-value of 0.001. For very severe or death, it was 0.884 with a p-value of 127. And for death, it was 0.819 with a p-value of 0.092. The p-value for death is larger than that for severe outcome or death because there were many fewer deaths. From the use of the estimated covariance matrix for the Whelan-Weisfeld method, the average hazard ratio with equal weights for each time to event endpoint is 0.836 with a 0.743 to 0.941 as the confidence interval and two-sided p-value of 0.003. With the method of Lehmacher, statistical significance at alpha equal 0.05 would apply to the outcome of severe outcome or death, since the pairwise averages of its hazard ratio with those for very severe death or death itself also had two-sided p-values less than 0.05. There are also non-parametric randomization-based methods using log rank tests and less stringent assumptions that provided comparable results and are described in the reference. This next example is a different approach using composite endpoints, and it pertains to a study of rheumatoid arthritis and focuses on measures of severity for rheumatoid arthritis. For rheumatoid arthritis, there's a core set of 7 measures for improvement, and they include 3 physician assessments: tender joint count, swollen joint count, physician global rating, 3 patient assessments: disability, pain, patient global rating, and a biologic measure known as acute phase reactant, which are either the ESR or the CRP. Felsen developed with others the ACR20 composite endpoint as a dichotomy, with success being 20% improvement in both tender and swollen joint counts, and also at least 3 of 5 of the other measures. This composite endpoint has recognition in FDA guidance documents, and it can be the primary criterion for efficacy in rheumatoid arthritis trials. It enables the management of multiplicity for the core set through a single composite endpoint. And composite endpoints like this have also been identified as relevant in other areas informing inflammatory disorders. There is a related definition for ACR50, and so consideration of the sum of ACR20 plus ACR50 as a trichotomous endpoint is also possible when reasonably satisfactory power applies to both. And if statistical significance at one-sided alpha applies, then inferential assessment of both ACR20 and ACR50 is possible without any other multiplicity adjustment. Because if you contradict the null hypothesis for the sum of ACR20 and ACR50, at most one of them can be null, and that's why they can then be tested separately at the full alpha level once one has contradicted the null hypothesis for the sum of them. And the sum of them is also relevant because it is addressing both the overall composite that is addressing all of the components, but it also gives higher weighting to improvement by 50% than to improvement by 20%. There is another type of management of multiple comparisons that applies for vaccine efficacy studies. A clinical trial will compare a test vaccine to a standard vaccine with 100 to 300 patients per treatment group for M antibody measurements, where M can be between 3 and 10, but in some such studies could be as large as 20. A criterion for non-inferiority of the new vaccine to the standard vaccine is that all antibody measurements have their ratios of geometric means for test versus reference be at least 2/3 on the basis of the lower limits of two-sided 90% or 95% confidence intervals. And the rationale for this is that this is preserving at least 2/3 of the benefit of the test regimen relative to placebo over the reference regimen, because placebo would have a geometric mean near 0. Since the correlation among the M antibody measurements tend to be small to moderate, the power to demonstrate non-inferiority for all M antibody measurements typically is comparable to the product of the M univariate powers for the respective antibody measures. For example, if M equals 8 and the univariate power is 98% for each separate measurement, the power to demonstrate non-inferiority for all of them would be exceeding 0.98 to the 8th power, or about 85%. Here, control of type 2 error or power is the multiplicity issue. This issue also arises in clinical trials where there are co-primary endpoints, because when endpoints are identified as co-primary, there has to be statistical significance for all of them. And so that basically means that the power needs to account for the type 2 error for each of them. And so again, the power will be somewhere near the product of the separate powers. And so in this case, the multiplicity issue is on the type 2 error rather than on the type 1 error, as we've described previously. Another scenario for addressing multiplicity are studies in which there are clinical trials that assess 2 or more doses of a test treatment or placebo. But these studies could also include an active reference control. They also could include both placebo and an active reference control if they need to show differences from placebo, and also need to show differences or non-inferiority relative to the active control. There also can be response surfaces with combinations of 2 or more doses of a test drug and 1 or more doses of an active reference control and or placebo. In this particular case, there are multiple comparisons between the doses of the test agent and the control. There could also be multiple comparisons among the doses of the test drug with each other. And finally, there could be multiple comparisons to assess non-inferiority relative to the active control. The strategies for managing these comparisons could be hierarchical or sequential, such that the comparison of the high dose to placebo is made first, and then the comparison of the next highest dose is made to placebo. This can be reasonable if the dose-response relationship is expected to be monotonic, and there are not tolerability or safety concerns that could undermine the efficacy of the high dose because of patient discontinuation for tolerability issues and imputation that would assign unfavorable outcomes to patients who discontinue due to tolerability. So other methods involve closed testing, in which there is essentially a focus on averages of doses against control, or alpha propagation methods like the Bonferroni method that we mentioned earlier, or a method called Hawkberg, where if there are 2 doses compared to control, if both have p less than alpha, both are efficacious. But if the bigger p-value exceeds alpha, then one can still look at the other dose at alpha over 2. So in this particular case, if the better dose performs well, then one can avoid a dilemma from the other dose not performing well. In this particular study, there were about 100 patients per group. It included a test treatment, a reference treatment, and placebo for healing rates of duodenal ulcer. The healing rates were 80% for the test treatment, 74% for the reference treatment, and 50% for placebo. In this particular trial, there was actually an issue more for type 2 error than type 1 error, because the test treatment needed to be superior to placebo, and it also had to be non-inferior to the reference treatment. And for that non-inferiority to be interpretable, the reference treatment also had to be superior to placebo. So in this case, all of the assessments could be done at the one-sided 0.25 level, or alternatively the two-sided 0.5 level. In this example, both test and reference were superior to placebo, as well as the test treatment being non-inferior to the reference control. So again, when all comparisons must be successful, they all can be done at full alpha, but there does need to be management of multiplicity for the type 2 error, because all of the separate endpoints need to be highly powered so that the sum of their type 2 errors is well below 10%. So the power for success for all will be sufficiently high. This is another type of related clinical trial to compare 3 treatments for duodenal ulcer for both healing and avoidance of ulcer recurrence. It had included a placebo, a reference treatment, and a test treatment. One outcome was duodenal ulcer healing. The other outcome was healing and no recurrence. The test treatment needed to be better than placebo for both healing as well as healing with no recurrence, and it needed to be better than the reference treatment for healing with no recurrence. Also, the reference treatment needed to be better than placebo for healing. The 2 assessments for Part C are made first at the one-sided 0.25 level, so that one at least can establish that the new treatment is better than placebo. And the Hochberg method was used. So if both p-values were less than 0.25, both were successful. And if that occurred, then one could then proceed to look at the hypothesis in D at the one-sided 0.25 level. And if it had p less than 0.25, then finally the hypothesis in E is assessed at the 0.25 level. It is important to avoid excessive type 2 error, particularly with respect to the combination of hypotheses that had to be addressed. In this particular example, there's a clinical trial to compare a high dose and a medium dose and a low dose of a test treatment to placebo for survival of patients with a fatal disorder. In this particular comparison, because both the high dose and the medium dose were expected to be efficacious and the sample size was limited, the first assessment was to pool the high and medium dose together and compare them against the placebo at one-sided alpha. This again is looking at an average. And if the average is statistically significant at one-sided 0.25, then one can look separately at the high dose and the medium dose, both at one-sided 0.25. And again, if the pooling of high and medium versus placebo is significant, the null hypothesis cannot apply to both high and medium. At most, one of them can be null, and that's why step 2 is possible with separate assessments for them at the one-sided 0.25 level. So again, by closed testing, the first test is rejecting the intersection of the 2 separate doses, and that allows the separate assessments in step 2. The third assessment is the low dose versus placebo, because the low dose was not necessarily expected to be efficacious. Also, adjustment for specified covariates can provide stronger results without necessarily any adjustment, but mainly by variance reduction. The one-sided p-values are shown here. With the unadjusted methods, the comparison that pertained to the log rank test unadjusted for the pooling of the 2 doses was a 0.025 for a one-sided p-value, so that was indeed rejected. But for the separate doses, it was not. But for the adjusted test for the covariates, all of the assessments were statistically significant for both the log rank test as well as for the Wilcoxon test. In this example, we are focusing on a situation that often arises and has some complexity. A study may have 2 or more primary hypotheses for a first objective and 1 or more additional hypotheses as a second objective. So this includes a study to compare test and control for 2 primary endpoints as the first objective and for 1 key secondary endpoint as the second objective, or a study to compare high and low dose to control for 1 primary endpoint as the first objective and for 1 key secondary endpoint as the second objective. or a study to demonstrate non-inferiority of high dose and low dose to active control reference treatment as the first objective, and to demonstrate superiority of high and low dose to the control as the second objective. The closed testing procedures to control the experiment type 1 error at alpha for studies with two or more primary hypotheses as the first objective, and one or more primary or secondary hypotheses can be complex. If we let H01 and H02 denote the two hypotheses for the first objective, and H03 denote the hypothesis for the second objective, one strategy, which is sometimes called a serial gatekeeper, is to apply the Hochberg method to H01 and H02 first, and only if both have P less than alpha is H03 tested at alpha. Now, what this means is that if both of them have P less than alpha, one can then proceed to H03. If one of them has P greater than alpha, the other can be tested at alpha/2 and can still have success, but there cannot be proceeding to the H03. And the mathematics for how this relates to closed testing is shown in A, B, C, or D. A second strategy, which is sometimes called a parallel gatekeeper, is to assess H01 and H02 first in a way which enables assessment of H03 second. And if either H01 or H02 is rejected by a Bonferroni method by P less than alpha, then one can then proceed to test H03 at P less than alpha over 2 as well. So again, if H01 or H02 have P less than alpha/2, then one can then test H03 at alpha/2. If H03 also has P less than alpha/2, by what is called recycling, the alpha/2 can be recycled back to the one that was not rejected at alpha/2 and retested at alpha. And so in that particular way, one can indeed get back and test one of these primary hypotheses at a higher alpha if both H01 or if both the one with the p-value less than alpha 2 as well as the H03 have p less than alpha over 2. So more simply, if two of them have p less than alpha over 2, the other one can be tested at full alpha. Furthermore, if all three of them have P less than alpha, there is a way of basically rejecting all three of them. These strategies can become more complex when the number of hypotheses for the first objective is greater than or equal to 3, or the number of hypotheses for the second objective is greater than or equal alpha/2. But this is talked about in one of the references, a recently published paper with Ouyang and others, that I may note later. This example here is a clinical trial with essentially a response surface design. It involved combinations of treatment. Diastolic blood pressure was the primary endpoint. Multiplicity was managed for the primary endpoint by basically looking at a particular comparison against its particular monotherapies at the 0.5 level. And again, in this particular case, these comparisons are primary. So both need to be rejected at the 0.5 level, two-sided with effect sizes in the predicted direction, or at the one-sided 0.25 level. That indeed occurred for this study. And subsequently, two other combinations were compared to their monotherapies using the Hochberg method. And so if both had P less than 0.025 one-sided, then both were rejected. But if one of them failed that, the other one could still be rejected at 0.0125. Secondary endpoints in this case were looked at more informally. In this particular case, the strategies for managing comparisons between treatments for an overall population and one or more subgroups can be of interest. And in this case, there can be different ways of managing the subgroups. One can either proceed hierarchically by testing the subgroup first at full alpha and then testing the overall population, when higher power is believed to apply to the subgroup. Alternatively, Hochberg's method can be applied to the subgroup in the overall population. It's also possible to apply an alpha propagation method. In this example, there are 3 treatments: a treatment B that is a combination of A and C for a urinary tract infection, as well as A and C. The primary population was all patients, and the subgroup of interest were those with a complicated diagnosis. For efficacy to apply the combination, it must be superior to both of the components. Multiplicity for populations was managed with Hochberg's method, so one either needed to have P less than 0.25 for both B versus A and B versus C for both all populations and for the subgroup, or one needed one-sided P to be less than 0.125 for both B versus A and B versus C for at least one population. For both populations, the one-sided P was less than 0.002 for both B versus A and B versus C, and so efficacy of B did indeed apply to both of the populations. There was further assessment of the other subgroup to confirm that the effect size was in the predicted direction, although the sensitivity to treatment differences in the uncomplicated diagnosis was much less apparent because the uncomplicated diagnosis was not as sensitive to treatment effects as the complicated diagnosis patients were. In this particular example, there is a double-blind, placebo-controlled global trial to look at coronary arterial disease as post-myocardial infarction in about 18,000 patients. And there was also cerebrovascular disease in about 5,000 patients and peripheral arterial disease in 4,000 patients. The primary endpoint was time to the first occurrence of CV death, MI, stroke, or urgent coronary revascularization. And a key secondary endpoint was time to CV death, MI, or stroke. In a separate trial for a different indication, there was unacceptable benefit risk for CVD patients. And so 3 populations became of interest: all patients with CAD or PAD, and then only the CAD patients, because that was a substantial majority of the patients. Both the primary endpoint and the secondary endpoint could have been primary with the Lehmacher method used to manage multiplicity through the Whelan-Weisfeld method. Multiplicity for the 3 populations could have been addressed formally in a sequential way, with all patients first, CAD plus PAD second, and CAD third, given one-sided P less than 0.25 for both endpoints at the previous step. For both endpoints, all 3 populations did have one-sided P less than 0.25. It is also possible to have multi-stage trials to evaluate successively more stringent criteria for rare events. For a new treatment to manage type 2 diabetes, a clinical trial to exclude major adverse cardiovascular events is potentially necessary. There are 3 primary null hypotheses. One corresponds to showing that the relative risk comparing the new treatment to control does not exceed 1.8 from a non-inferiority safety point of view. If that occurs, one is interested in whether it exceeds 1.3, and if that occurs, there's interest in whether it exceeds 1.0. These assessments can be done at successive interim analyses that are successively well-powered, and the reference describes that. And so there can be separate alpha spending functions for the first hypothesis, the second hypothesis, and the third hypothesis, where for the third hypothesis, most of the alpha is saved for the overall sample size, whereas for the first 2 hypotheses, there are interim assessments to identify whether the study is on course. Well-planned statistical strategies can enable a clinical trial to have better findings through study designs with better representation of patient population, better compliance with the protocol, and sufficient sample size for study objectives, and also have better data quality through methods for reducing prevalence of missing data and protocol violations. and also analysis plans that pre-specify covariance adjustment with respect to prognostic baseline factors to increase statistical power through reduced variance, and with pre-specified multiplicity procedures to support robustness from spurious events through appropriate control of type 1 error in the strong sense. Thank you for your attention. We can now have discussion. I was going to point out that on this slide, you'll see second from the bottom, a reference to a paper by Ouyang, Zhang, Carol Lee, and myself that was published in 2019 in the Journal of Biopharmaceutical Statistics. And it identifies a very useful way for doing closed testing for a clinical trial that has 2 or 3 doses, a primary endpoint, and perhaps 2 or 3 key secondary endpoints as well. Although these procedures can become complex, although they are straightforward to invoke, and they do control type 1 error.